Dear student, today we shall discuss the different type of pulmonary tuberculosis. So in the previous class we have discussed the etiopathogenesis of tuberculosis and the development and evaluation of the most pathognomic lesion in the tuberculosis infection, that was granuloma. So now the pulmonary tuberculosis is of two types. The first one is known as primary tuberculosis and another is known as secondary tuberculosis, which may complicate in the different form of tuberculosis. So the primary tuberculosis, let us try to understand primary tuberculosis. Primary tuberculosis means that the infection of an individual who has not been previously infected or sensitized or exposed or come into the contact of tuberculous bacterial infection, meaning by this is the first time infection by the tuberculous bacterial infection. First time the individual is infected, first time the immunological reaction is going to occur, first time he is sensitized against the tuberculous bacterial infection, or first time he come into the contact or exposed to the bacterial infection. So in that situation, the development of tuberculosis is known as primary tuberculosis. Most commonly it is seen in the childhood. In the childhood, first he come into the contact with the tuberculous bacterial infection, he develop the primary tuberculosis. The primary tuberculosis is mainly characterized by a very important structural changes in the affected part of the lung. There is formation of primary complex और घोन कॉम्प्लेक्स, इसका दो नाम है, ये प्राइमरी कॉम्प्लेक्स और घोन कॉम्प्लेक्स. द प्राइमरी कॉम्प्लेक्स और घोन कॉम्प्लेक्स means that in the affected part of the lung there is this infection involve three main components. The first, the lung parenchyma, that is the pulmonary component, which undergo the inflammation in the form of tuberculous pneumonia. This infection may proceed and involve the lymphatic channel, lymphatic vessel, which undergo in the form of lymphangitis, and lastly the draining lymph node, mostly the hilar lymph node in the lung, undergo inflammation, chronic inflammation, actually chronic granulomatous inflammation, they enlarge, and that is known as lymphadenitis. So there are three main involvement, three site, three region in the lung parenchyma involvement, and that is collectively known as primary complex. So in primary complex or bone complex, what are the three components? First, the pulmonary component, meaning by the lung parenchyma is undergo infection and in the form of tuberculous pneumonia. The second, the lymphatic vessel undergo inflammation, that is in the form of lymphangitis, and lastly the draining lymph node, especially the hilar lymph node, is going to involve in the form of lymphadenitis. So these three components consist or collectively form the complex known as primary complex, which is the very characteristic feature of primary pulmonary tuberculosis. Don't confuse that primary tuberculosis, the lung is the primary site, but it can also be happen in the lymph node, especially mesenteric lymph node or hilar lymph node, or even intestine or a tonsil. So different other site may also undergo primary tuberculosis, but lung is the very important most common site, and the primary complex or bone complex is formed in the lung. So let us try to understand the three main components, what is going to structural changes. The first component is pulmonary component. This component, the lesion start where the bacteria, bacterial infection or bacteria lodges in the lung parenchyma. So lung parenchyma undergo inflammation in the form of tuberculous pneumonia in the consolidated area, and that is about 1 to 2 cm solitary lesion seen in the lung parenchyma, and a special location is very important. Location is just below the pleura, subpleural lesion, at the interlobular fissure, and the most important site or region is that in the lower part of the upper lobe and upper part of the lower lobe. So you just note the exact location of, that is the characteristic location of primary focus और घून फोकस, इसको हम लोग बोलते हैं प्राइमरी फोकस और घून फोकस इन द लंग parenchyma. Where it is located? Just below the pleura, meaning by the subpleural. Where? In the interlobular fissure. What is the exact location? That is the lower part of the upper lobe and upper part of the lower lobe. So this region is the very typical area and initial area. That lesion is known as primary focus or घून focus. Here the tuberculosis infection start, and they start their characteristic lesion in the form of first tuberculous pneumonia. As the disease progresses, there may be caseous necrosis will be seen along with the granulomatous inflammatory reaction, formation of granuloma can be seen, but initially there is only a consolidated area is seen in this particular region of the lung parenchyma. The second component is the lymphatic vessel. The draining, the lymphatic of the lung undergo bacterial infection and undergo inflammation, and that inflammation lead to the chronic lymphangitis. Inflammation of the lymphatic is known as lymphangitis. So in this situation, the lymphatic channel, the wall has got beaded beaded form of macrophages laden with the Mycobacterium tuberculi, and there is a focal area of the caseous necrosis. So in this there is a miliary tubercle is going to form in the wall of the affected lymphatic channel. So that appears just like a millet-like structure, millet seed-like structure in the form of tuberculi and tubercle, which contain macrophages along with the tuberculous bacilli on the wall of the lymphatic channel. So this is known as this is the changes that is seen in the affected lymphatic. The third component, that the lymph node is going to affected, and the most commonly the hilar lymph node is going to affected by the tuberculous bacterial infection. It undergo enlargement. The size of the lymph node is going to enlarge, and the chronic granulomatous inflammation is going to start in the affected lymph node in the form of central caseous necrosis, in the form of surrounding fibrosis and collection of epithelioid cell, meaning by the granulomatous changes, granulomatous reaction, granulomatous formation is going to start in the affected lymph node. How? Because of there is central caseous necrosis surrounded by the fibrosis, and there is collection of epithelioid cell. So in this way, the affected lymph node is going to involve, meaning by the whole picture of the chronic granulomatous inflammatory changes will be seen in the affected lesion, pulmonary, lymphatic as well as lymph node. So these three components collectively form primary complex or Ghon complex. It is very, very important. That question is very much asked in the form of short notes, that what do you mean by primary complex in the Viva examination also. Now there are some fate of primary complex. द प्राइमरी कम्प्लेक्स जब एक बार बन जाता है तो उसका क्या असर होता है, क्या क्या उसमें पॉसिबिलिटी है, क्या क्या चेंजेस हो सकता है. सो इन केस ऑफ मोस्ट कॉमनली इन मोस्ट ऑफ द केसेस दिस अंडरगो स्पॉन्टेनियस हीलिंग. Spontaneous healing is going to happen, so the patient recover very soon following after the exposure of bacterial infection, because of the healing process is start, and healing start in the form of fibrosis and calcification in the affected area. So dystrophic calcification and fibrotic changes going to start, and the lesion is going to spontaneously recover or healed. Sometimes the lesion has got the tuberculous bacilli. The caseous material, caseous necrotic material has got tuberculous bacteria. So this caseous material along with the bacteria can spread in the lung parenchyma through the lymphatic or through the hematogenous route from one side to the another side, or from even in the other lung also. So there is a progression of the disease inside the lung parenchyma from one side to the another side. So that is known as प्राइमरी प्रोग्रेसिव पल्मोनरी ट्यूबरकुलोसिस. इसको हम लोग क्या बोलते हैं? प्राइमरी पल्मोनरी ट्यूबरकुलोसिस. मीनिंग बाई द ट्यूबरकुलस इज गोइंग ऑन प्रोग्रेस. एक जगह से दूसरे जगह को इन्वॉल्व कर लेगा थ्रू द बैक्टीरिया कैन ट्रेवल अलॉन्ग विद द लिम्फो हेमेटोजेनियस स्प्रेड. सो इस तरह से बैक्टीरिया एक जगह से दूसरे जगह जा कर के इन्फेक्ट कर लेगा और उसको हम लोग बोलते हैं प्राइमरी प्रोग्रेसिव पल्मोनरी ट्यूबरकुलोसिस. तो एक संभावना है. तीसरी संभावना ये है कि देयर मे बी चांस ऑफ मिलियरी ट्यूबरकुलोसिस. मिलियरी ट्यूबरकुलोसिस मीन्स द बैक्टीरिया फ्रॉम द लंग along with the hematogenous route or through the blood vessel can spread from lung to the another tissue like liver, another lymph node, or brain, or meninges, or bone, or intestine, so on the tonsil. So bacteria can travel through the hematogenous route from the primary site, from the lung, and that lead to the development of a disseminated form of tuberculosis that is known as secondary, and that is known as miliary tuberculosis. So there may be this possibility. A third possibility that is going to happen in the primary tuberculosis, as you know that the primary tuberculosis is a asymptomatic condition. The patient can recover without any treatment due to the healing process or due to the immunological reaction. It is spontaneously recovered most of the cases, but the bacteria remain inside the caseous necrotic material or in the granuloma. So this bacteria remain in the inapparent stage for some interval, but when the immunological status of the patient is going to change or depress, especially in the HIV patient suffering from HIV infection or immunosuppressive therapy or corticosteroid therapy, anyhow when the immunological status of the patient is going to suppress, then there may be chance of reactivation. This bacteria can reactivate, and that may lead to the aggressive form of tuberculosis, and that is known as secondary tuberculosis. So in this way the secondary tuberculosis can be happen. So a primary tuberculosis का चार असर हुआ, या तो ये स्पॉन्टेनियसली रिकवर कर जाएगा बाय द प्रोसेस ऑफ हीलिंग, फाइब्रोसिस, कैल्सिफिकेशन, या इट मे इन्वॉल्व द अदर साइड ऑफ द लंग इनसाइड द फ्रॉम द प्राइमरी साइड टू द अदर साइड in the same lung or other lung. So that may lead to the primary progressive pulmonary tuberculosis, or it may take form the miliary tuberculosis, can spread to the distant organ involved, and the last one is it may cause secondary tuberculosis. So in this way the primary tuberculosis can be changed into the other form. So this is something about the primary tuberculosis. You must know the definition of primary tuberculosis, the different component of primary complex or home complex, and the microscopic changes in the different component, and last the fate of the primary tuberculosis you must know. Now come to the secondary tuberculosis. As it is clear from the name that it is secondary, meaning by the patient or the individual has got history of previous infection or previous contact of tuberculous bacterial infection. So there is a history that the patient has got previously sensitized or previously infected or previously immunized against tuberculous bacterial infection. But प्राइमरी में क्या था कि पेशेंट को डायरेक्ट फर्स्ट टाइम कॉन्टेक्ट में आया था, लेकिन यहाँ पर क्या है कि देयर इज़ previous history that he has already infected by the tuberculous bacterial infection, or he has got sensitization or he has got immunological reaction against the tuberculous bacterial infection. So that is known as secondary tuberculosis. Secondary tuberculosis generally occurs in the adult stage when the patient has got additive or come into the contact of tuberculous bacterial infection. The infection can be occurs in two ways, either by the exogenous route or by the endogenous. Endogenous route means when the bacteria remain inside the lung parenchyma, especially in case of primary tuberculosis, and which is going to reactivate, and that may lead to the secondary tuberculosis. बैक्टीरिया पहले से मौजूद था, जैसे ही इम्यूनोलॉजिकल स्टेटस डिस्टर्ब हुआ फिर रीएक्टिवेट होकर के सेकेंडरी ट्यूबरकुलोसिस करा दिया, तो ये इंडोजीनियस हुआ जो कि पहले से ही मौजूद था. और इट मे बी एक्सोजीनियस, मीनिंग बाई देयर इज अ डायरेक्ट एंट्री ऑफ द बैक्टीरिया, and that bacterial entry, as you know, that they are from the different channel by the different route or different mode of spread. In the previous class we have discussed by that the bacteria can enter into the body either by the inhalation of the air drop containing tuberculous bacteria or by the ingestion of the infected material containing tuberculous bacilli, or it may lung can be involved by the hematogenous spread from the distant side. The bacteria can go to the lung parenchyma, or from the lymphatic channel the bacteria can travel from the lymph node, it may involve the lung parenchyma. So in this way there are different channel, different route, different way of spread of tuberculous bacterial infection. From the distant side it can go to the lung parenchyma and involve and start the tuberculous granulomatous tuberculous inflammatory reaction, and that the disease is going to progress. So in this way the secondary tuberculosis is going to occur. Again in the lung, in case of secondary tuberculosis, the most specific site in the affected part of the lung is apex, and all of you know that why it is apex is the favorable site for the growth of bacteria, because here there is the oxygen tension is high. So in this way, जहाँ प्राइमरी में लोकस अलग था, कहाँ था, in the subpleural region, interlobular area, and the lower part of the upper lobe and upper part of the lower lobe, वो एरिया था, स्पेसिफिक एरिया प्राइमरी में था. यहाँ पर क्या है, इन द सेकेंडरी ट्यूबरकुलोसिस द अफेक्शन द एरिया इज इन द एपिकल एरिया, बिकॉज इट हैज़ गॉट हाई ऑक्सीजन टेंशन. इट इज गिव ए फेवरेबल मीडिया for the growth of the bacteria. So bacteria lodges first time in the apical area, and that area just appear as a consolidated area because of initially the bacterial infection causes tuberculous pneumonia. Lung parenchyma is going to inflame, and that is lead to the formation of consolidation about 1 to 2 cm in diameter. There is a consolidated area is going to form in the apical region of the tuberculous, apical region of the lung. When the disease progresses, as the disease progresses, there are different type of manifestation is going to seen in the lung parenchyma, pulmonary as well as the secondary. Initially जैसे ही tuberculous bacterial का lodgement हुआ, they start the inflammatory reaction, chronic inflammation is going to start, and that area appear as a consolidated area in the X-ray as well as in the pathological changes in the form of consolidation or solidification. In the X-ray it appears just like a white opaque area. So that is the consolidated area because of tuberculous pneumonia. But as the disease progresses, according to the duration of the disease, according to the virulence of the bacteria, according to the immunological status of the host, immune response, according to the early diagnosis and treatment of the bacterial infection, there is a progression of the secondary tuberculosis. The secondary tuberculosis can be progressed in the different way, different form. It can if the treatment is not start as early as possible, if the diagnosis is not done as early as possible, if the patient status, immunological status is not so good, if the patient has got alcoholic or he has smoking, then in this kind of factor may causes progression of secondary tuberculosis in the different form. The first form of the tuberculosis in secondary tuberculosis is that again it can be healed or it can undergo fibrosis or calcification or dystrophic calcification of fibrotic changes start in the affected region in the lung parenchyma, and it can spontaneously recover. But in the secondary tuberculosis, it is not so happen. It progresses, and in the progresses, first of all, it causes tuberculous pneumonia. Then it develops into the form of chronic granulomatous inflammatory changes in the affected part of the lung parenchyma. Here there is a fully development of granuloma. All of you know that how the granuloma is formed and what are the component of granuloma. क्या होगा कि जैसे ही इन्फ्लामेशन होगा, जैसे ही इंट्री होगा, वहाँ पर ग्रेनुलोमा फॉर्मेशन शुरू होगा और लास्ट में द फुल्ली ग्रेनुलोमा इज फॉर्म इन द फॉर्म ऑफ सेंट्रल केजियस नेक्रोसिस surrounded by the epithelioid cell, surrounded by the rim of lymphocyte, and in the outermost area there is a fibrotic septa, and there is a two type of giant cell, Langer's giant cell and foreign body giant cell, and the central area there is a pink granular eosinophilic material in the form of caseous necrosis. So this type of lesion is going to form in the affected lung parenchyma, and that granuloma formation lead to progression of disease in the different form in the pulmonary involvement, and it can also involve the extrapulmonary region also. So let us see what are the changes, what are the complication of this secondary tuberculosis in the lung as well as outside the lung. So in the lung, the second possibility is that when the pneumonia से जैसे ही आगे बढ़ेगा उसके बाद there is development of fibrocaseous tuberculosis. उसके बाद क्या होगा? Fibrocaseous tuberculosis. So in this situation there is formation of granuloma, and there is formation of a very characteristic lesion in the form of cavity. So जहाँ consolidation होता है tuberculous pneumonia में शुरू में उस निमोनिया उस कंसोलिडेटेड एरिया के अंदर द केजियस नेक्रोसिस जो हुआ बिकॉज ऑफ द केजियस नेक्रोसिस डिस्ट्रक्शन ऑफ द सेल, द नेक्रोटिक मटेरियल इज गोइंग टू in necrosis is going to in more advanced, more aggressive form, and that may lead to the massive destruction of the lung parenchyma, and that lead to the formation of cavity. So there is a cavity formation is the second incidence following after the bacterial infection. Bacterial infection के बाद tuberculous pneumonia हुआ, उसके बाद consolidation हुआ, उसके बाद consolidation के अंदर cavity बनने लगा. तो there is a formation of cavity, and when the cavity is going to form, it create a lot of problem. क्या problem होगा? तो when the cavity is formed, this cavity contain eosinophilic granular pink-like caseous exudative material, and that material has got tuberculous bacilli. So this tuberculous bacilli along with the caseous material, along with the exudative material, can spread from one side to the another side. So first of all, this cavity may lead to the formation of fistula along with the pleura. So there is a formation of pleural ब्रोंकियल फिस्टुला, ब्रोंकाई और प्लूरा के बीच में एक रास्ता बन जाता है. दैट में लीड टू द प्लूरोब्रोंकियल फिस्टुला, एंड थ्रू दिस फिस्टुला द एक्जुडेटिव मटेरियल containing acid fast bacilli, tuberculous bacilli, can spread and involve the pleura, and when the pleura is going to involve, there is the inflammation is going to start in the pleural cavity, First of all, there is inflammation that lead to the pleuritis or pleurisy. When the inflammation is going to in more advanced stage, there is a accumulation of the fluid in the pleural cavity, lead to the pleural effusion. The effusion, the material, the fluid material is usually fibro or serous in nature. Their fibrin content may lead to the thickening or adhesion of the pleura, so there is pleural thickening, and sometimes the pleural, the exudative material or whole material is going to transform into the pus, and so there is accumulation of the pus in the pleural cavity in the form of empyema. So in this way, the pleura is going to involve, and various kind of the manifestation is going to seen because of the entry of bacteria along with the exudative material through the cavity into the pleural cavity through the fistula formation. So in this way, the pleura is going to involve. The pleura remains adherent to the lung parenchyma, so it is very commonly and very early affected in the form of pleurisy, pleural effusion, or pleural thickening, or pleural or empyema. So there are 4 types of disorders, abnormalities seen in the pleura because of the secondary tuberculosis. At the same time, not only that this cavity lead to the spread of the tuberculous bacilli to the bronchi, लंग पैरेन्काइमा से सीधे ब्रोंकाई में आ गया, और इंडोट्रैकियल और इंडोब्रैंकियल tuberculosis कैन बी सीन फ्रॉम द हियर if the caseous material along with the exudative material along with the tuberculous bacteria is swallowed or ingested through the GIT, it can lodge into the intestine and lead to the intestinal tuberculosis. So from the lung, the tuberculous bacilli along with the caseous material along with the exudative material can spread from one side to the another side, and that may lead to the pulmonary as well as extrapulmonary complication, tuberculosis. In the same lung, there may be chance of development of tuberculosis. From the primary side, it can involve the other lung also through the lympho-hematogenous spread of bacilli along with the exudative material. So if it enters into the pulmonary vein, that can lead to the spread of the infection to the distant organ like liver, kidney, spleen, brain, meninges, bone, spine, tube, salpingitis, meaning by the fallopian tube, intestine. So all organ can be affected by the spread of the tuberculous bacilli along with the pulmonary vessel, especially pulmonary vein. If the bacteria enters into the pulmonary artery, it can spread to the other lung. एक lung से दूसरे lung में भी जा सकता है. There may be chance of spread of tuberculous bacilli, and that whole phenomena, that whole thing is known as miliary tuberculosis. तो miliary tuberculosis क्या हुआ? That is the spread, that is the dissemination of the Mycobacterium tuberculi from the lung to the other organ, from the lung to the other lung, एक लंग से दूसरे लंग में हो या एक लंग से कहीं और डिस्टेंट ऑर्गन में चला जाए, तो दैट होल फिनोमेना is happen through the hematogenous route, a spread of the bacteria through the hematogenous route, and that is known as miliary tuberculosis. मिलियरी इसलिए नाम दिया गया है बिकॉज ऑफ देयर नेचर दैट द लीजन इज जस्ट लाइक मिलेट. जहाँ भी ये मिलियरी ट्यूबरकुलोसिस होता है, या इधर लंग में हो या कहीं और जगह हो, तो लीजन ग्रॉसली अपीयर्स जस्ट लाइक ए मिलेट सीड साइज, एंड द साइज इज अबाउट 1 mm in diameter. It appears yellowish, firm area without grossly visible caseous necrosis. बहुत स्मॉल एरिया मिलेट के रूप में दिखाई पड़ता है, ग्रॉसली विदाउट केजियस नेक्रोसिस. सो दिस इज नोन एज मिलियर. सो दैट इज वाई द नेम इज गिवन मिलियरी tuberculosis. And if you study in the microscope, you will find that the tubercle with minute area of caseous necrosis is seen. Tubercle is formed with caseous necrosis in the microscopic examination. So that is known as miliary tuberculosis because of the nature of the lesion. Lesion is very small, very millet seed-like structure, having a small caseous necrosis. A small tubercle is going to form here in the case of miliary tuberculosis. So this is the miliary tuberculosis. The cavity, which is the very important lesion, that is the whole extra and pulmonary complication is going to happen because of the cavity formation. So what is the gross and microscopic picture of this cavity in the lung parenchyma? Grossly, the cavity has got a spherical in shape, and there is fibrocollagenous thick wall उसका fibrocollagenous रहता है, and it is lined by alveus caseous necrotic material. The lumen contain pink granular eosinophilic material, and that is caseous necrotic material. The lumen is filled with eosinophilic granular caseous material. So this is the whole structure that can be seen by the microscope grossly. The blood vessel has got thrombosed blood vessel. There around the cavity there is a formation of consolidation area, and the adjacent pleura is also involved in the form of thickening. So the cavity, where the cavity is formed, their lumen is filled with the exudative material, caseous material, pink granular-like material, eosinophilic material. It is lined by the fibrocollagenous wall, thick wall, which has got a surrounding area of consolidation. So in this way, the cavitary lesion is seen in the lung parenchyma. And if you go for the microscopic examination, you will find that this area has got fully developed granuloma, and all component of granuloma will be seen in this area, like epithelioid cells, caseous necrosis, macrophages, lymphocyte, fibroblast. All cells can be seen. So in this way, the pulmonary and extrapulmonary complication is going to develop, and that whole depends upon the progression of the disease, secondary tuberculosis, the early diagnosis, treatment, as well as the immunological status of the patient. Different type of progression of the secondary tuberculosis can be seen in the both lung as well as in the extrapulmonary area. So diagnosis of the is very simple. By the clinical feature, it can be diagnosed by the patient generally present with the systemic as well as the respiratory system. Systemic, there is a evening rise of temperature, anorexia, weight loss, weakness, malaise, and there is a respiratory symptom like in the form of cough with expectoration. Expectoration is mucopurulent in nature. The patient may has got chest pain, sometimes breathlessness is also seen, and the most important finding that there may be chance of hemoptysis. So the respiratory symptom as well as the systemic symptom may develop, and that is going to seen in the patient, and this may create a suspicion of tuberculosis patient. Evening rise of temperature, anorexia, weight loss, weakness, malaise, and followed by the respiratory system in the form of cough with expectoration, along with the cough with expectoration, along with the hemoptysis. Sputum is very important, because the sputum examination is very important for the diagnosis and confirmation of the tuberculosis infection. So sometimes if the sputum is not present, we generally diagnose on the basis of clinical feature as well as on the basis of X-ray and serological or any other examination. But when the sputum is produced, in the suspected case, we send a sputum for the isolation of the bacteria, that is for the confirmation of tuberculosis infection. And a sputum examination is done in two ways, either by the staining method, that is done in the laboratory, and or by the culture method in the LG media. So the bacteria can be isolated and identified in the sputum, and that give the confirmatory diagnosis of tuberculosis. But as the disease sometimes sputum production is not sufficient to detect the tuberculous bacterial infection, so we take the help of chest X-ray examination. So chest X-ray examination is a very common screening as well as diagnostic test in the day-to-day practice, in the day-to-day practice of the seeing the patient of tuberculosis. And the X-ray finding very much suggestive that in the secondary tuberculosis there is the apical area has got consolidation or white opacity and calcification that can be seen in the chest X-ray examination. In the lung parenchyma, the hilar lymph node is going to enlarge, and if the pleura is going to involve, there may be effusion, there may be accumulation of the fluid or a pus that can be seen in the X-ray examination. So X-ray examination is very, very important for the conclusive diagnosis of the tuberculosis infection. But if it is not difficulty, then we can take other test like CBC examination. We will see that the lymphocyte count is going to increase, the ESR is going to increase. Sometimes molecular diagnosis can be done if the facility is available, and sometimes a screening test is very important. A screening test is done by the tuberculin test that is known as Mantoux test, and that test is detect the delayed type of hypersensitivity reaction which is seen in the tuberculous bacterial infection. So in the tuberculous bacterial infection, there is delayed type of hypersensitivity reaction, type 4 hypersensitivity reaction is going to seen. So it is detected in the laboratory by the test that is known as Mantoux test, and it is very much helpful in the screening of the tuberculous infection. But don't be confused that if the tuberculosis has got limitation. If the Mantoux test is positive, that does not mean that the patient is suffering from tuberculosis. But if it is negative, it says that the patient has no tuberculosis. But if it is positive, that means not wholly that the patient is tuberculosis, because in case of miliary tuberculosis, it sometimes become negative. So in this way, it is a screening test for the primary tuberculosis. It is very important, especially in the childhood. It just can be done, but it is just a screening test, not a diagnostic test. Sometimes other tests like radiographic procedure along with the CT scan to know the extent of the lesion, it may be sometimes helpful for the differential diagnosis. So in this way, the diagnosis of tuberculosis is made, but the most exact diagnosis is only made by डिटेक्शन ऑफ बैक्टीरिया इफ पॉसिबल. अगर बैक्टीरिया मिल गया तब तो कोई कहने में दिक्कत नहीं है कि पेशेंट को ट्यूबरकुलोसिस नहीं है, लेकिन नहीं मिला तो कोई ज़रूरी नहीं है कि पेशेंट को टीबी नहीं है. पेशेंट को और भी सारे चीज़ को भी हम लोग क्राइटेरिया को लेकर के चलते हैं. द क्लिनिकल प्रेजेंटेशन, द हिस्ट्री, द स्क्रीनिंग टेस्ट, द एक्सरे फाइंडिंग, द स्पूटम फाइंडिंग, द सेरोलॉजिकल फाइंडिंग like detection of antibody against the TB tuberculosis infection in the form of IgG, TB IgG or TB IgM, their detection by correlating all these findings, the clinical history along with the respiratory examination finding, all findings are correlated, and then we are able to reach the final diagnosis of tuberculosis. And when the diagnosis is confirmed, we start very quickly with the all important drug like isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. All drugs are given in proper course, proper dose and proper duration. Duration is very important, and in this way the TB tuberculosis is controlled as well as cured as well as prevented also. So in this way the tuberculosis, pulmonary tuberculosis is complete. In the next class we shall start another disease of respiratory system. I think COPD will be started. Until thank you.